Good afternoon, everyone. Let me take this opportunity to welcome you to our third Pediatric Emergency Medicine series, talking about pediatric emergency medicine staffs. This is more important because in emergency situations, we all, especially healthcare providers, we know sometimes what we're going through when we see very sick child which need our attentions, and more challenging if sometimes you're not sure what to do. So welcome to this pediatric series, and this is going to be on monthly basis. Every month, date like this, we'll have one talk regarding one component of pediatric series. With that, do not let me want to welcome you again, and more important, just few house rules. Please, everyone, make sure you mute your mic. There will be a time to unmute when you want to ask questions or you want to give a comment on that. But otherwise, everyone who joins, make sure your microphone is muted. Only presenter should allow to give what they prepared for us today. Other house rules, this talk, it's registered to medical council, and all who attended this session from beginning to the end, they will have a CPD points. So more important for us to just drop your registration number, your full name and registration number to the message part of this chat, so as we could keep records and submit your names and your number for your CPD points after these sessions. Without wasting time, let me welcome our first presenter. But before our first presenter introduced, I'm going to introduce myself as a chair of this session today. My name is Dr. Saidi Kilindimo. I'm an emergency physician from Simbila University. Along with our two presenters, Dr. Brittany and Dr. Alphonce Simbila, who is going to give our talk. So our first presenter. Let me mute. Our first presenter will be Dr. Alphonce Simbila, who is going to introduce our talk today and give the first part of the session. Dr. Alphonce, the floor is yours. Welcome.
Thank you very much, moderator, Dr. Said Dimo. It's an honor to co-host this talk with Professor Brittany. For those people who do not know, Professor Brittany is speaking from Atlanta. Thanks to the courtesy of technology, she's been very instrumental in emergency medicine residence training at the MUHAS, and she's now championing or working towards establishing pediatric emergency medicine training in Tanzania. She's known me since the early years of my career, so this is a great honor. Thank you very much, Professor. So if we can share the slides now.
They should be on the screen.
Okay, so our talk today is on pediatric trauma. And can you mute our mic, please? So the talk today is on pediatric trauma, and the focus is on important considerations when we're taking care of pediatric trauma. So this is going to take us through a few things. As you see in the overview, we are going to talk about how children get injured, depending on their ages and the activities that they're involved in. The mechanisms of injury can be varied. We are also going to see what makes pediatric trauma unique in terms of the primary survey in the early hours and early approaches, the secondary survey, and we'll go through the general considerations And through cases, we are going to learn about specific conditions in pediatric trauma. So without wasting any time, Professor Britt, could you kindly take us through some useful statistics and epidemiology on pediatric trauma? Professor,
Sure.
please.
So today we're going to be talking about pediatric trauma, and it is such an important topic because trauma is the leading cause of death in children greater than 1 year of age worldwide. What we do in the emergency department can actually make a huge difference in reducing poor outcomes, the morbidity and mortality after children are injured. And what we do in the emergency department has actually become more and more important in the management of pediatric trauma over the last decade or two. And that's because we've gone away from a lot of surgical management of pediatric trauma to a lot of conservative non-surgical management. Those are the things that we start in the EMD. We have also focused a lot on treating pain in pediatric trauma, safely reducing radiation, so making sure that we are decreasing the number of radiology exams that are not needed, but making sure that we get those that are needed. And emergency medicine physicians have taken a lead in safely preventing injury. So telling communities what is injuring children and how they can avoid it. So overall, in pediatric trauma, the emergency care provider has a much larger role. We can do important things in this area. So let's talk about how children get hurt, the mechanisms of injury. Of pediatric injuries that present to healthcare facilities, so injuries that are bad enough that parents bring their children to the hospital, worldwide, we see the same thing. Motor vehicle crashes account for the majority of trauma-related deaths in the world, and falls account for the majority of non-fatal injuries. Other injuries that we see are really based on a patient's age, and they have to do with the developmental stage of the child. So if you think of young children, those that are 4 and younger, those are kids that are really learning how to walk, learning how to explore their world, and they don't know what is safe or not safe. So those are the kids that we see getting burns and bites from exploring their environment and touching things that they should not be touching. In older children, school-aged children from 5 to 9 years of age, they start to get a little bit more independent. They have the ability to walk to places by themselves. We start to see bicycle and pedestrian-related injuries in that age group. For older children, those that are 9 and older, we start to see patterns of injury that sort of mimic those of adults. We see increased fatal and non-fatal motor vehicle accidents. We see increased risk of self-harm, of violence, so being injured by somebody else. And unfortunately, in older teens, we see unsafe work conditions. So as kids grow, we see different mechanisms of injury. That gives us an idea of what we could use for injury prevention and what we can tell our communities about. Different ages of children also mean different injuries because in almost every body system, there are important anatomic and physiologic differences that make children respond to trauma differently. This results in different injury patterns, and we're going to be talking about those throughout our lecture today. So whenever we see a trauma patient in the EMD, we begin by doing a primary trauma survey, our initial assessment of that patient, and I'm going to send this lecture back over to Dr. Simbila to discuss the primary trauma survey.
Thank you very much, Professor. And just like in adult trauma primary survey, the pediatric trauma primary survey aims to identify or recognize life-threatening injuries. And it doesn't end there. It also entails intervening to mitigate immediate life threats or threats to life or limb. And this is usually conducted through the first 5 minutes. Its components include the airway, the breathing, circulation, disability, exposure, and specific to children, there are 2 additional components of family involvement and the use of point of care ultrasound to see whether there's free fluid or not. You need to know that in the pediatric population, weight is an additional vital sign. In addition to such things as the heart rate, the blood pressure, the saturation of oxygen, you have an additional vital sign, which is weight, since everything that is given to these children is weight-based. And there are many ways of estimating this weight. As depicted in the previous slide, there is this tape that is called a Breslow tape that can be used to estimate weight. So when we are assessing the airway, we're actually assessing for patency and ability to protect it. And we want to establish if it's obstructed or not, or whether there is inability to maintain its patency. So we look for obstruction and we look for inability to keep it patent. And there are ways that can tell us, or there are signs that can tell us that this airway is either patent or it's compromised. For example, if you see such things as blood in the mouth, or secretions, or there are objects that are obstructing the airway, you need to know that now the airway is compromised. So on intervention part, there are maneuvers that can be used to make sure that you can open the airway. For example, since we are talking about trauma, the one maneuver that is considered helpful and safe in opening the airway is the jaw thrust, unlike the head tilt chin lift maneuver, which tends to stretch or flex or extend the spine. And in a setting of trauma, we need to know that the C-spine can be injured. And by doing the head tilt chin lift, you can further damage the C-spine and cause more injury. So suctioning is another thing that can be done when you're intervening on the airway pipes. But once you've suctioned, you've positioned, and they still cannot keep the airway open, you have an option of using airway adjuncts. As you look at the slide, the topmost right is the nasopharyngeal airway. The middle part is the oropharyngeal airway. So if things go south and deteriorate, you need to consider securing the airway using an endotracheal tube that is intubated. And remember that when you're doing all these airway maneuvers and maintenance, you need to put the spine or the spinal column in a neutral position while stabilizing. There are indications to whether you need to move into intubation, things such as a low Glasgow coma score of 8 and less, or the need for prolonged or controlled airway. So in children, there are differences to the airway that need to also be taken care of or to be considered. For example, the children have a large occiput, and in most cases, we nurse them in a supine position. While placed supine, the occiput can flex the neck and cause airway obstruction. They have smaller airways compared to adults. They have large tongues compared to their mouths, which can also be the sole or the only reason for airway obstruction. They have a soft and short trachea. Their airways, like the larynx, is high up and very anterior. So when you are intubating, you need to consider its position anatomically. You have a U-shaped epiglottis, and the narrowest place or the narrowest part in their airway is the subglottic or cricoid ring. So keep in mind that you may be faced with a difficult airway with all these anatomical variations. So it's important that you estimate the devices that you're going to use. And in the slide, you have a formula that is used to estimate the size of an endotracheal tube. And by definition, or by this formula, you need to use the age in years divided by 4 plus 3.5 if you're going to use a cuffed endotracheal tube, or plus 4 if it's uncuffed endotracheal tube. This is very important for your preparation and safety of the airways in children. Moving to the B part. So breathing assessment also needs us to actively see or look for chest rise, see if the chest is rising. And in children, usually the chest rise goes hand in hand with the abdominal movement. You want to listen using your stethoscope, whether you have bilateral echo air entry. Look for signs of distress as signified by either a very high respiratory rate or a very low or too slow respiratory rate, which is also problematic. There may be nasal flaring and retractions or use of intercostal muscles or muscles of respiration to signify that they are in distress. You are always to connect them to a monitor so that you can constantly see their oxygen saturation levels. While intervening on the breathing part, you may be needed to provide oxygen, or if the ventilatory effort is low, you can temporize your intervention by using the bag mask valve device. You're also needed to, or you're advised to put an NG tube to decompress the stomach, because that poses a danger in aspiration, which can worsen the breathing. If everything deteriorates fast, or if need be, you may be needed to intubate. And because this primary survey is more of a clinical assessment, sometimes you may be faced with features suggestive of a tension pneumothorax, and a needed decompression may be needed. So, just like in the airway, there are differences to consider in children's breathing. So, children tend to have a mobile mediastinum. And by it being mobile, there is an advantage and disadvantage to it. The mobility can decrease the risk of major vessel and airway injuries, but it tends to compromise ventilatory and cardiovascular effort, and it rapidly compromises its functionality. They have thin chest walls, meaning this cannot protect the thoracic organs very well. They use the diaphragm to breathe. Their ribs are horizontally oriented, more horizontally oriented, which limits expansion and hence hinders breathing effort. They have more of type 2 fibers, which are fast twitch fibers, and they are designed for short bursts of power. And they contract quickly, but they fatigue very easily, unlike the first or the type 1 muscle fibers, which are for endurance, like in adults. So you need to be very watchful and be careful for respiratory compromise, given this fact. So in circulation, the assessment of circulation is to ensure that we recognize shock very easily using the assessment parameters such as the heart rate, blood pressure, which usually goes down very late in their natural history. Capillary refill, you need to know whether the capillary refill is delayed or normal. You want to establish if the extremities are warm or cold. And of course, mentation goes hand in hand with all these parameters, which is a typical or is a classical presentation of a shocked patient. Then in the intervention part, or its intervention includes an establishment of an IV access. Most often we establish peripheral IV access using age-appropriate large bore IV cannulas. And if it's difficult, you are to move quickly to intraosseous access. Then you may be needed to stop ongoing hemorrhage if there is active, visible, or obvious hemorrhage. In the intervention, you have a room to give a 20 mils per kg IV bolus of crystalloids that is normal saline or lactated drinkers. Then you're to repeat whenever this is needed. And if there is active bleeding, as a rule in trauma, blood out, blood in. Please transfuse, because by giving more fluid, you're doing hemodilution and it's detrimental. Keep in mind that the vitals in children, they are age dependent. So you need to know the normal heart rates and BP ranges depending on the age. And to help you in the pediatric population, there's a formula for estimating the minimum systolic blood pressure that is needed. So minimum systolic blood pressure equals 70 plus age in years times 2 in brackets. That is in millimeters of mercury. This is a very useful formula that can come in handy when you're resuscitating. So note that children have different circulation and response to hemorrhage. For example, children can lose up to 30 to 45% of their blood volumes without a drop in blood pressure. And they decompensate later than adults. So they hang in there for a long time. But once they start deteriorating, it is usually very rapid. So the first response to blood loss in children is usually a raise in the heart rate, which is tachycardia. Once you peak shock using hypotension in the pediatric population, this is a very late sign, and it usually is a very concerning finding. So this is an important thing to note. So when we are assessing disability, or the disability assessment entails an objective assessment of the brain and spine functions. We use age-appropriate Glasgow Coma Scale score to establish the ammentation level. Or you can opt to use the AVPU scale and find out whether they're mentating normally or not. And the AVPU, if you are to expand it, A stands for alert, whether they are alert and interacting to stimuli, or they are only responding to voice, or they're responding to pain, or whether they are responsive, which is a very bad level. Then, to establish whether the spine is injured or not, you need to look for phonoaudible deficit or gross deficit. One other thing that needs to be noted in the pediatric population is the random blood glucose. In stress-like trauma, the PEDS population usually runs into hypoglycemia. And the reasons being children have fewer glycogen stores. So assessment of RBG, or random blood glucose, or checking blood glucose in any child with trauma or who becomes altered is a very important intervention, or it's a very important thing to do. Moving to exposure. So we need to fully expose the child, looking for injuries. So we fully undress them. We look under everything, that is head to toe. As we know that skin is the largest organ, and it can be the only area that can tell us about the severity and location of injuries. We also log roll and look at the back, because the back can also conceal potential injuries. But after doing the exposure, you should know that you should quickly cover them, because children also tend to get hypothermic very fast due to large body surface area relative to their body mass. So as soon as you're done with the exposure, kindly cover them to avoid hypothermia. And an additional component in the pediatric care is the involvement of family to get useful information. Since children may not be able to talk, there's also a room to use point of care ultrasound, which usually looks for free fluid independent areas. And in a setting of trauma, any fluid is considered blood until proven otherwise. So take note, you have a room to use the family that is around. Now, the secondary survey is nothing but an organized head-to-toe exam. And when you're doing this, you must make sure that you've resuscitated and they are now stable, they're out of the woods. Then you can do your systematic, organized head-to-toe examination to make sure that you do not miss any life-threatening conditions. And once you establish that there is a life-threatening condition, you are required to go back to the primary survey, intervene, and move on before you go to the secondary survey. So this is also an excellent time to consider laboratory investigations and imaging. As part of a bridge between the primary survey and the secondary survey, we have what we call the sample history, which is a quick history that can inform you on such things as the signs and symptoms, whether they have known allergies or not, whether they are on medications. You need to know, if you need to know about the past medical history that maybe contributes to their presentation as trauma patients, when did they last eat, and all the events that led to the injury. So it's a quick way of obtaining all this information for you to proceed with the resuscitation. Then there is a component of pain control and tetanus prevention. So it has been observed that pain is an underrated component in the management of trauma in children, probably because they are not very communicative. And in the pain management, there are many modes of doing it. You can use age-appropriate doses of analgesic medications. Such things as immobilization of injured extremities significantly reduces the pain and starts the healing process. There is a room for psychological techniques, such things as the use of videos, cartoons to distract them from their painful experiences. And more importantly, you need to make sure that their tetanus vaccination schedule is updated. And if not, you are to vaccinate them, give them tetanus toxoid, and they should be safe. I'll now let Professor Britt talk about the pediatric trauma general considerations. Please, Prof.
Thank you so much. That was an excellent introduction to the primary and secondary survey in pediatric trauma patients. As you can see, many of the elements are similar to taking care of adult trauma patients, but there are essential differences that we need to consider. In this section, I'm going to go through some of the general considerations that we apply to pediatric trauma patients. So when we consider adults versus kids, we know they get different injuries, and there are specific reasons this happens. One of the reasons is that adults have harder external skeletons. And so when an adult has an injury that is going to cause an internal injury, you normally see broken bones. However, in pediatric patients, their bones are very elastic and plastic, so they can actually have significant heart and lung injuries without broken ribs. Kids can also have significant abdominal injuries because they have thin abdominal walls without necessarily looking like they have significant trauma on the outside. So whenever you're seeing a child with an injury, even if you don't see obvious external signs, you have to worry about internal damage. Kids are simply also smaller than adults, so the same amount of force causes different injuries. It can cause multiple and more severe injuries in children. For example, if you imagine a child being hit by a car, that car is more likely to hit them in their upper body to cause a head injury, pushing them backwards, and to end up rolling over them. If you think of an adult being hit by a car, it's more likely to injure their legs and cause them to go over the car and into the windshield. Just simply different mechanisms based on size. Kids also have a larger body surface area, and that can result in heat loss. This is especially important in children who are burned and lose that protective skin barrier.
I bring that girl barely towards.
Compared to adults, as Dr. Simbila mentioned, kids have a much higher metabolic demand, so they go through energy and calories more quickly. That means that they use up their limited glycogen stores very quickly. Often after trauma, children are not eating and drinking. And so the combination of using up all of that energy and not eating and drinking leads to a lot of hypoglycemia in this population. If you have a sudden change in a trauma patient, you want to make sure that you check their glucose and make sure that that is not the cause of their altered mental status, as well as considering trauma-specific causes such as head injury. Kids also go through oxygen extraction a lot more quickly than adults, which makes them more prone to having hypoxia. You want to make sure that you are providing oxygen and giving glucose-containing IV fluids for children with trauma to ensure that these things are considered. We're now going to go through some pediatric trauma cases that provide specific examples of different body part injuries, what we watch out for specifically in children, and what we would do in the EMD for each of these cases. We're going to be starting with an injury, a head injury. So this is a 9-month-old infant who we think was sitting on a tabletop that was about 1 meter high. She reached for a toy, something that kids often do, and she missed it, falling to the floor, landing on her head. She had a loss of consciousness of less than 2 minutes, has a head swelling of her forehead, and is very fussy. With that, she comes to the emergency department. Some things that we want to consider when we think about kids with head injuries is that their anatomy is different. They have big heads in proportion to their body size, which makes them more likely to injure their head. There's just simply more weight there that can pull their head down with a fall and cause it to be injured. However, when they have a head injury, they have a little bit more room in their cranium. They have a fontanelle if they're young enough, and they have a somewhat pliable or flexible cranium with open sutures a lot of the time. That means if they have intracranial injury with swelling, they have a little bit of room to swell. However, their brains are less myelinated and have higher water content, which makes them more prone to injury. Because of that extra room inside their cranium and the pliability, that means that they actually deal with elevated intracranial pressure due to injury pretty well until it's very bad. If you begin to see Cushing's triad, bradycardia, hypertension, irregular respirations in a child, you begin to see those other physical exam findings of elevated ICP. It is a very late finding, and that child is going to deteriorate very quickly on you. Whenever we're talking about head injuries, we also have to consider spine injuries, because if you injure your head, you can often injure your spine by the same mechanism. Kids have a lot of elasticity of the ligaments and joints in their spine, and they have less calcified cartilaginous structures and not a lot of musculature. Their muscles are not yet strong. That combined with their large head makes them much more likely to have a spinal cord injury without radiographic abnormality or SCIWARA. So they can actually have spinal cord injuries that look normal on X-ray. Most of the time, MRI will show these injuries, but X-ray and CT may not. Kids are also more likely to have higher spinal cord injuries because those heavy heads make them have an anatomic fulcrum, or an area where their neck goes back and forth, that is higher than adults. The anatomic fulcrum of children is around C2, C3, whereas in adults, it's the lower C-spine. That makes kids more prone to having higher C-spine injuries with extreme force. So as we consider those important anatomic differences in kids, what do we do when we see a head injury like the one described at the emergency department? Dr. Simbila, will you take us through what to do at the EMD?
Certainly. Wow, there are many considerations to the pediatric population. No wonder the outcomes may not be very well, may not be very good on this side of the world. But so if we are to use this case and consider what should be done at the EMD, we can generally approach this by, first of all, conducting a proper primary assessment in trauma. That is the A, B, C, D, E, including the family and using the POCUS. So the primary assessment is both assessment and intervention to make sure that the life-threatening issues are taken care of. But pertinent to this case, we are actively advised to manage raised intracranial pressure if we suspect it. So if you have a child with altered mentation, a child who's vomiting, a child who is deteriorating with a typical history of trauma, you want to consider early management of ICP, such things as giving mannitol or 3% saline, making sure that they oxygenate very well, and things of the sort. The other thing is consideration of other serious injuries. I talked about the management of airway in conjunction with the C-spine. So that is an important part too, because once the C-spine is gone, everything else goes south. There is a role of frequent clinical assessment to examine for signs of deterioration. For so long as you have a child with you, in front of you, you need to be frequently assessing them and reassessing them. And there's the use of urgent CT scans. So ruling out C-spine injuries and other injuries, you may use an urgent CT scan with the help of critical decision rules. There is what we call the PEM, which is beyond the scope of this talk today, but it's a criteria that can easily tell you what to do as far as a CT scan is concerned or imaging is concerned. So you're also needed to decide very early whether you're transferring them for this urgent CT or any other further neurosurgical or critical care services. So you need to do that early on. It's very important. Okay. The other part in the initial assessment in the primary survey, when you're conducting a primary survey in such a case, the aim is to identify severe head injury at risk of raised intracranial pressure. And that can also enable you to do immediate investigations, manage them, or do a proper and prompt referral. As we all know, most parts of our country and across Africa and many parts of the world, they may not be able to take care of critically ill children, such as the head injured children. So you need to know when you do your referral. The other thing that the initial primary assessment helps you to do is to score them. To score the kids. You risk stratify them. There are those who are low risk that just need observation, and there are those in the intermediate risk and high risk that need further management elsewhere. Then you are to identify concerning issues, other issues such as non-accidental injuries. So injuries in children can be caused by such things as abuse. They can be behind abuse practices and they attempt non-accidental injuries. And this is a talk for another day, but you need to know that if you have an injured patient who is a pediatric patient, you want to consider non-accidental injuries as part of the spectrum in their illness. There are also considerations in alternative diagnosis. You also have, there's a role of eliciting useful history and knowing or understanding the mechanism of injury, because this is very important. For such histories like autoaugmentation, vomiting, seizure, loss of consciousness, that tells you how bad or how risky this illness or this injury is. The mechanism of the injury, things like fall from height. For example, the child fell from a table. If the table is more than two times the height of the child or the infant, that is considered a high risk mechanism that can translate into more detrimental or more lethal injuries in the head. Other mechanisms of injury are like motor traffic accidents. When you're told that they have been knocked by a fast moving car, maybe, you want to anticipate that the injuries can also be equally fatal. And as I talked earlier, there are special considerations like non-accidental injuries and alternative diagnosis. So you then move, as the case dictates, to do a secondary survey, a head-to-toe exam, as we talked about earlier. Make sure that you maintain the neutral cervical spine position. There are important features that you can elicit or see or identify when you're conducting your secondary survey. Things like level of consciousness and signs of raised ICP, as I talked about. There may be open or depressed skull fractures as witnessed by either a hematoma or a bulgy swelling of the head. Usually, this should bother you. If you have a huge hematoma or a bulgy swelling, consider checking whether there is an open skull fracture or depressed skull fracture. There are also things like signs of base of the skull fracture, like the raccoon eyes, the dark coloration around the eyes. Then establish if there is any focal neurological deficit to see if the spine is injured and other trauma like the non-accidental injuries. I cannot overemphasize on that. So all in all, in the last part, you need to determine appropriate disposition for transfer for such a child. As the case is read, that is a sick child. So prompt transfer or disposition is also part of the care at the emergency department. So as we saw the case, our late Professor Britt now give us a summary of what actually is there.
And so in this case, we had some clues that it might be a more serious injury. She had a swelling on her head that was obvious, had a loss of consciousness, and was very fussy, so not normal when she got to the emergency department. In the EMD, she had fairly rapid neurologic deterioration. She's became less responsive, hypertensive, and bradycardic. Those are the Cushing's triad telling us there's elevated ICP. She was intubated for airway protection in this case, but we did maintain cervical spine alignment. She was given mannitol and the head of her bed was put at 30 degrees to help lower ICP as much as we could. A CT scan was done that showed an epidural hematoma, and she was urgently transferred to neurosurgery. So that's just an example of the EMD course and considerations for head injury in the pediatric trauma population. In our next case, we're going to be discussing chest and abdomen injuries in kids. So in this case, a 7-year-old boy in grade 1 was brought to the EMD by the police after being struck by a fast-moving car while crossing the road. As we talked about earlier, if you think of a younger child being struck by a car, they're much more likely to be hit in their chest, abdomen, or even head and neck than an adult who is more likely to be hit in their lower extremities. This patient arrives to the EMD conscious, but he is complaining of a lot of abdominal pain and difficulty breathing. So as we think about chest injuries in children, there's some big anatomic and physiologic differences. As we discussed earlier, the rib cages and bones in general are more compliant. So their rib cage is compressible and they can have significant pulmonary contusions and cardiac injuries without even having a broken bone. This makes them less likely to have pneumothoraces, which normally happen because of broken bones puncturing lungs, but more likely to have very serious pulmonary contusions. Kids also have very mobile mediastinums, which means that if they do have something like a tension pneumothorax, it can actually push their mediastinum over much further than we see in adults. So they have a little bit of room where they can sort of compensate for those injuries, but as soon as you begin to see them deteriorate, it's going to happen very quickly. With abdominal injuries, there's some very important anatomic differences between children and adults. They've got bigger, solid organs when you think of them proportionally. They have thinner abdominal walls on top of this and less subcutaneous fat. This combination of things makes their organs much more likely to be injured when they are hit in the abdomen. Their livers and spleens are more anterior, and so those are the places where we see significant injuries in children quite frequently, which is less likely to happen in adults. So they have a very high chance of injury to their spleen and their livers. They can also have delayed injuries. So if a child is hit, especially in the upper abdomen, we think about this in bicycle handlebar injuries, where kids go over the handlebar and the handlebar hits them in the upper abdomen. They can have a pancreatic injury or a small bowel injury that doesn't present initially. They just get a bruise internally then, but if it continues and worsens, they can have significant delayed injuries. So kids that present 2 or 3 days after trauma with abdominal pain need to be considered very carefully. So I will hand it over to Dr. Simbila to talk about what we would do in the EMD in a case such as the one presented.
Thank you, Professor Britt, for letting us know that some injuries can be delayed in presentation in the pediatric population. Now, what should be done at the emergency department? Or what are the options? Again, initial approach will consider both the abdominal and chest injuries. So we'll start as usual with the primary survey, but you need to tailor this primary survey based on what you already have in the information, in the prior information. For example, for abdominal trauma, despite the fact that the abdomen is injured, the child seems to be in labored breathing. So you need to consider the airway and C-spine support. And in the breathing, you may be needed to give oxygen and plus or minus ventilatory support. In the circulation part, as I said, we need to consider shock and hemorrhage control. Don't forget concealed blood that can also present with shock, but no obvious hemorrhage. In the disability part, take care of pain scales. So do the scaling and look for level of consciousness. Do not forget the RBG. Again, do not forget the RBG because they can turn hypoglycemic due to stress. On exposure, after you've looked for everything, you've addressed them, you've done the log roll, please cover them, taking note that they can turn hypothermic very quickly too. So as you've noted, I've divided this primary survey in this case into the abdominal pertinent primary survey which will translate or will go into the ample history, as I said, or sample history. Then you'll go to trauma secondary survey, which is head to toe. So as far as abdominal injuries are concerned, in the secondary survey, you want to look for bruising, abrasions, lacerations, and abdominal distension, which can tell you that there is something that is going on in the abdomen. You also want to exclude tenderness, rebound tenderness, guarding, or rigidity of the abdomen, which can either tell you that there's something very serious going on and needs a surgical intervention. Then there's the pelvis. The pelvis can conceal a lot of blood. When you're doing your secondary survey, this is the time that you may be needed to do a pelvic binder if there are signs that tells you that they can be bleeding or they're in shock because the pelvis is involved as part of the abdomen and it's losing a lot of blood. So you can also move and complete your examination of the abdomen or the secondary survey of the abdomen by doing a rectal exam to pick the rectal tone and the possibility of spinal injury and whether there's blood that tells you that there is more injuries. Then issues pertinent to chest trauma in the primary survey. So in the airway, you want to ensure patterns, but also exclude airway injuries because trauma may not be isolated to the chest only. Or in your assessment of the airway, such things like the position of the trachea can tell you, in the assessment of the position of the trachea, it can tell you whether maybe you're dealing with a tension pneumo that has pushed everything else to the contralateral side. In the breathing part, together with the assessment of the air entry and other issues, you want to provide high flow oxygen because the child is in distress, percussive downers or auscultate for echo air entry for you to exclude tension pneumothorax. Examine the chest for any tenderness, which may tell you that maybe they have a rib fracture that is causing all this pain. Look for any frail segments in case of a frail chest. Look for obvious wounds.
Simbila, unmute your mic.
Can you hear me there?
Yes, we
Yes,
can.
Where did I lose you? In the breathing part?
yes, proceed
Or
from there.
circulation?
Yes.
Okay, so I was saying in breathing, you may be needed to give oxygen because as the case told us, the child was sort of in distress, struggling to breathe. So support them with oxygen. Then do your percussion for downers, auscultation to see if there is echo entry. And when you're doing this, you're trying to rule out such conditions like tension pneumothorax, and you want to examine for tenderness, frail segments, and whether there are wounds that need to be covered using a three-sided occlusive taping. Then move and assess whether they're in shock or not in the circulation. Intervene by establishing IV access and give the necessary fluid or blood where needed. Then, as usual, complement your assessment by the sample history, a quick sample history that can add to your management. Then move to trauma secondary survey, which is an organized head-to-toe assessment, as we said. Now, specific for this case, we will concentrate on its presentation, which points towards a pulmonary contusion as it was unveiled by Professor Britt in the previous slides. So in case of a pulmonary contusion, this one can occur in absence of rib fractures in children, or there may be no external signs as you've listened to the special considerations in pediatric population. So in this condition, the chest X-ray can show increased pulmonary opacities. These are changes that may not be there at the time that you're taking it. So people advise taking a CT, which can reveal contusions very well that may not be very obvious in plain films. So if you move to a CT, you may be able to see changes that a plain chest X-ray missed. Then in terms of management at the ED, oxygen supplementation is very important. You may require non-invasive or invasive ventilation, depending on which direction the illness moves. Then give analgesia. We should not forget the fact that they're in pain. The most common presentation of trauma and injuries is pain, be it in adults or pediatric population. So give analgesia as indicated, that is depending on the age and the weight. Then avoid excessive intravenous fluid. And you want to do a survey of other injuries, such things like hemopneumothorax, the rib fractures, the mediastinal injuries, and the pulmonary lacerations, which may also be there. I would now let Professor Britt take us through a summary of the case that we presented.
So in this
Professor Britt.
case, the patient was mildly tachycardic but had a normal blood pressure in the EMD. That gives us a clue that they are losing some blood or having injury, but not in that shock state as of yet. They were tachypnic and hypoxic with saturations in the mid-80s. We provided oxygen with a non-rebreather mask, and there was improvement in the saturation. We gave morphine for pain relief, and a hemoglobin point-of-care test was normal. The x-rays, as we've alluded to, did show significant pulmonary contusions. The FAST exam was negative for free fluid, but the CT scan did show us a liver laceration. This patient was then admitted to the pediatric surgery floor for continued support with oxygen and conservative management of the intra-abdominal injuries. We'll now move on to our third and final case. This is a case of an extremity injury. While playing football at school, Juma, a 12-year-old in 7th grade, reported twisting his right leg after colliding with Samuel, an opposing player. He was unable to stand after the collision and observed an obvious deformity to the leg. When we think about extremity injuries in children, there are some really important anatomical considerations. And the main thing is that pediatric skeletons are immature, they're prone to fractures around the growth plates, the physes, and green stick fractures, which are bends in the bone. The main thing that we want to worry about with pediatric orthopedic injuries is that if we don't manage them properly when we first see them, this can lead to lifelong disability. So if we don't correct deformity or we ignore growth plate fractures, this can lead to limb length discrepancies and serious disabilities for the rest of their life. The opposite is also true, however. They have ability to heal almost anything. They have a lot of plasticity, and kids can grow and make up for injuries. So this is one of the areas where our management in the EMD is so important, because if we do the right thing, these children can go on to lead normal lives without disability in the majority of cases. So I'm going to hand it over to Dr. Simbila to talk about what we need to do in the EMD.
Thank you, Professor. So again, together with the initial pediatric trauma primary survey, at the emergency department, we should assess for pertinent issues. I'm very glad that you talked about the differences in growth plates, but in addition to that, in the initial primary survey, we need to assess for neurovascular status, especially for almost the teens or maybe adolescents. So these are, sometimes they have anatomical structures that are similar to adults. So assess neurovascular status. If there is any compromise, you may be needed to do an urgent reduction to save the limb, because the nervous system and the vascular system is compromised. But you need to move on and see and assess the integrity of the skin. So if you have a fracture and an overlying skin laceration maybe, or a wound, overlying wound, you may be needed to think that this is an open fracture whose management is different from a closed fracture, as we know. So sometimes you may also need to consult senior doctors, such as senior emergency physicians or orthopedic specialists, to urgently act on the compromised neurovascular status of the limb. And for such injuries like open fractures, in many settings, open fractures are taken as emergency conditions and they are managed like so. Don't forget analgesia. Once again, we tend to undertreat. Analgesia, analgesia, and analgesia again. Consider the need for reduction, be it closed reduction or open reduction. There are simple techniques that can alleviate pain, can initiate the healing, such things as immobilizing the limb using the right technique. So at the emergency department, we are supposed to be doing that, as we will see in the summary. Then there is a role for appropriate follow-up or transfer or admission thereof. So in a nutshell, this is, together with what Professor Britta said, this is what we should be doing in extremity fractures or extremity injuries as far as the pediatric population is concerned. I'll let now the Professor Britt take us through the summary of the case.
So in
Please,
this
Professor.
case, you can see a significant tibia fracture that includes angulation and it is displaced. In the EMD, there was no sign of skin being injured, so it was a closed fracture and it was neurovascularly intact. We provided ketamine sedation and reduced the fracture. And I found this one particularly interesting because you can see even after reduction, it looks a lot better, but it's certainly not a perfect reduction. I think that gives us a lot of sense of how plastic children's bodies are. They can heal very well if we give them the chance by doing a somewhat adequate reduction. In this case, this is after a couple months. You can see that the bone has remodeled, is very functional and well aligned, despite the imperfect reduction initially. So we really want to make sure that we give children the best shot when it comes to healing their orthopedic injuries well, by providing appropriate reduction, by providing appropriate immobilization, and in cases like this, making sure that they have follow-up that will ensure that this is growing and healing properly. As we talk about these cases, we often end them at what happened in the emergency department. But with trauma patients, it's very important to figure out where they should go and what should happen after we take care of them initially in the EMD. From across the world, it has been shown that moderately to severely injured children do better when they are taken care of by experts with pediatric specific expertise. So if your hospital does not have the ability to take care of these children that are severely injured in a pediatric specific area, you should consider if transfer makes sense for them. The emergency medicine provider should communicate directly with the receiving center to make sure that they have the adequate resources to take care of children. And of course, before transfer, you want to do everything that you can at your facility to maximize the stability of the patient so that they make it through transfer safely. You can also discuss what this would be with the receiving facility. In considering whether a child should be admitted or transferred, they need to be admitted or transferred if they require ongoing monitoring or surgical intervention. In general, if you are concerned that a child that has been injured will not have adequate support at home to heal, or would not be able to return to the EMD quickly if they were worsening, those are reasons to have them admitted or transferred for further observation to ensure that they are healing and make sure that they are good enough to go home before they're allowed to be discharged. If a patient is discharged to home, you should talk to their family very specifically about what would make them need to come back to the emergency department, back for reevaluation. We spoke about abdominal injuries in children and how they can have a delayed presentation, especially with small bowel or pancreatic injuries. So with an abdominal injury being sent home, you want to be very specific with that family about if this gets worse, they have worsening pain, they have vomiting, you'd want them to come right back for additional evaluation. So I'm going to hand it over to Dr. Simbila to give our key points as we wrap up our lecture.
Thank you, Prof. Thank you very much. Dear colleagues across the country and across the globe, wherever we are listening this talk from, up to this point, we have seen that children are not small adults. There are many things to consider as far as trauma is concerned in this population. Such things like anatomy creates differences in the injury patterns and the way we manage them. Also, decompensation can be very late, but more quickly than adults after an ongoing trauma. Again, children are not small adults. They are not equal to adults. Take into consideration all that we've talked about when we're managing them. And at this juncture, I would like to thank Professor Britt for allowing me to co-host this talk with her. I would also like to thank the moderator, Dr. Said, before we allow time for questions, comments, and additions. I hand the floor back to Dr. Said.
And thank you so much to you as well. Just before we hand it over to Said, I wanted to mention a few educational resources. So these are all wonderful online available resources to learn about pediatric emergency medicine and pediatric trauma. So I wanted to leave that up on the screen as we answer some questions.
Thank you very much, Prof.
All right. Thank you all the presenters for your time and nice take us through pediatric trauma. Many concepts I learned from this talk, and hope the audience also they learn a lot regarding pediatric trauma, especially what to do at the emergency department. I know the time has been not on our side. Let me allow a few questions, at least 2 or 3, if any, from the audience, before we close our discussion for today. Before you come to the question, let me drop again this message that put your number and your full name on the chat so as we could get your CPD points from these presentations. There's one question from Dr. Moyes, but didn't specify what was the situation. Just said, what if the child is 1 year old? Is it needed? Maybe Dr. Moyes, if you can hear us, can you clarify your questions so as the presenter will be able to give you the appropriate answers. Let me welcome any. I
was asking about
yes.
Whether tetanus is needed in a child less than 5 years. And is there any updates on that?
Right, our presenter will come to answer that question. Unless if no other question, I'll allow the presenters to answer the question. Let me allow another question, 1 or 2, before we allow the presenters to chip in. Another question? Comments? Addition? Correct. Maybe, dear presenters, can you respond to the Dr. Moy's question? He's asking about the tetanus toxoid. If the child is less than 1 year, is it needed? Is it necessary, or we can ignore? You're welcome. Any of the presenters.
Thank you, Dr. Moyes, for your question. In Tanzania, we have a vaccination schedule. For infants, we have combinations of vaccinations. So, for example, the DPT includes the tetanus vaccination within it. So, if the child is 1 year, they are likely to be covered within the initial schedule of immunization. So, you may not be needed to do that unless until maybe the wound is very dirty, where you need to give immunoglobulins around it. Unless otherwise there is an update to that. I do not know about US. I'll let Professor Britt talk about it.
It's the same. So if young children have their appropriate childhood vaccination series, they should be appropriately covered for tetanus. And so typically in younger children, we also don't worry about it that often, but you want to confirm with their family that they have been adequately vaccinated, or go ahead and look at their vaccine cards to be sure.
Thank you for the response to the questions. There's a comment from the floor. Dr. Beatrice is saying, congratulations, presenters and moderator, for these needed and detailed presentations. I reiterate, congratulations, presenters. That was well done and was clear to clarify a certain concept. Any one last question, if any?
Thank you very much.
Okay, if no more questions, no more comments, thank you, the audience, for your time to be with us on the third pediatric images series. And in 1 month time, we'll just soon tell you what will be the next topic. But in a month time, in 4 weeks, we'll have another 4th series of pediatric images talks from us. We're gonna leave the chat for the next 2-3 minutes before we close. Anybody didn't put their number and MCT registration, please drop it there so you could get your CPD. Otherwise, I thank all the presenters for a nice talk. I thank again all the audience for your time, and I thank myself managing to go through with this presentation. Until we meet next.
Thank you, Dr. Said.
Thanks everyone for joining.
Thank you, Prof.
Thank you, everyone.
Thanks, everyone. I'm going to leave the chat open for 1 more minute. If you have not put your MCT number and your name in yet, please do so. Thank you, everyone, for joining. I'm going to be closing the meeting now.